Apply topical anesthetic spray or jelly and vasoconstrictor spray into the nares to reduce the discomfort and bleeding associated with nasotracheal intubation. Select the appropriate size nasotracheal tube. Ensure that at least one tube a size smaller and one tube a size larger are available for difficult intubations. Check and prepare the intubation equipment, including the desired type of laryngoscope blade, straight or curved. Connect the laryngoscope blade to the handle and check the bulb for brightness. If not using a fiber optic blade, ensure that the laryngoscope blade bulb is secure. Use an appropriate size syringe to inflate the cuff on the tube and check for leaks. Completely deflate the cuff before intubating. Ensure that the self-inflating bag is attached to an oxygen source and that an appropriate size face mask is attached. Position the patient appropriately. Non-trauma patient. Place the patient supine with his or her head in a neutral or slightly sniffing position whereby the head is only slightly flexed. Trauma patient. Maintain the head in a neutral position with inline cervical spinal immobilization during the entire process of intubation. Do not flex or extend the neck of a patient with a suspected spinal cord injury. Perform hand hygiene, don gloves, and appropriate PPE based on the patient's signs and symptoms and indications for isolation precautions. Pre-oxygenate the patient for 3 to 5 minutes with 100% oxygen via a non-rebreather mask if ventilations are adequate, or via a self-inflating bag mask device if he or she is not adequately ventilating. Provide frequent and gentle breaths. If the patient is spontaneously breathing, use large bore tubing held at the airway to provide supplemental oxygen and to help prevent oxygen desaturation during the procedure. Lubricate the outside and tip of the tube with a local anesthetic jelly. Pick up and position the endotracheal tube so the natural curvature of the tube follows the natural curvature of the airway. Slowly insert the tube into the selected nares, using an initial upward motion just until the tube passes the nares. Then lower the angle of the tube and continue to guide it parallel along the hard palate until the tip is in the oropharynx just beyond the tip of the uvula. If the tube does not deflect downward, slightly rotate it and apply gentle pressure again. Do not use excessive pressure to force the tube into the airway. Gently advance the tube downward toward the glottis. Listen until maximal breath sounds are heard through the tube. While listening for the sound of air moving through the tube during inspiration, continue to advance the tube to approximately 1 to 2 centimeters above the larynx. Listen for the beginning of an inspiration and rapidly advance the tube the last 1 to 2 centimeters through the vocal cords. If necessary and not contraindicated, turn the patient's head to one side or flex the neck farther to facilitate the intubation. Immediately assess tube placement by observing the patient for coughing and increased condensation and air movement through the tube. If the tube can be successfully inserted blindly, continue with the procedure. If not, re-oxygenate the patient and consider other options. If intubation is unsuccessful within 30 seconds after placing the tube in the airway, remove the tube. If the patient's peripheral oxygen saturation, SpO2, drops after the tube is placed, remove the tube and oxygenate the patient with 100% oxygen. If the patient is not breathing sufficiently, use a bag mask device to oxygenate and ventilate him or her before reattempting intubation. If the tube cannot be inserted blindly, direct it into the trachea using a fiber optic bronchoscope or a laryngoscope and McGill forceps. Once the tube is in the oropharynx, place the patient in the sniffing position to open and observe the airway. Using a laryngoscope and blade in the left hand and the McGill forceps in the right hand, grasp the end of the tube just above the cuff and advance it anteriorly into the trachea. Be careful not to tear the cuff on the tube with the McGill forceps. When using the laryngoscope and blade, observe the endotracheal tube passing through the vocal cords until the cuff is no longer visible to ensure proper placement. Advance the tube another 2 to 4 centimeters into the trachea. Ensure that the tip of the tube is halfway between the vocal cords and the carina. For nasal intubation, common tube placement for the average adult should be greater than that of an oral endotracheal tube. The common oral tube placement for a female is 19 to 21 centimeters. For a male, 21 to 23 centimeters. Once the endotracheal tube is correctly placed, inflate the cuff. Follow the manufacturer's recommendations for inflating the spring-loaded pilot balloon with an appropriate size syringe. Maintain cuff pressure between 20 and 30 centimeters water. Confirm endotracheal tube placement while manually ventilating the patient with 100% oxygen. Improper insertion may result in severe hypoxemia, gastric distension, vomiting, and aspiration. Auscultate over the epigastrium. If air movement or gurgling is heard, esophageal intubation has occurred. Pull the tube back and reattempt intubation. Auscultate the lung bases and apices for bilateral breath sounds. Observe the chest wall for symmetric movement. Absence of chest wall movement on the left side may indicate right main stem intubation. Confirm the presence of carbon dioxide using one of these methods. Attach a disposable exhaled carbon dioxide CO2 detector to the patient's tube. Watch for a color change indicating the presence of carbon dioxide. Attach a continuous EtCO2 monitor, capnography, and watch for the detection of carbon dioxide. An effective cardiopulmonary resuscitation leads to a higher cardiac output. EtCO2 will rise, reflecting the increase in perfusion. Consider the use of an esophageal detection device during cardiac arrest in conjunction with physical assessment findings. The esophageal detection device's bulb is compressed and then placed on the end of the endotracheal tube. If the tip of the tube is in the airway, the bulb will inflate. Evaluate SpO2. If the tube is not correctly positioned, deflate the cuff and remove the tube immediately. Ventilate and hyperoxygenate the patient with 100% oxygen for 3 to 5 minutes before reattempting intubation or considering other options. If breath sounds are absent on the left, deflate the cuff, slightly withdraw the tube, and reevaluate the patient for bilateral breath sounds. When correctly positioned, the tube tip is halfway between the vocal cords and the carina. Connect the endotracheal tube to an oxygen source, self-inflating bag mask device, or mechanical ventilator using a swivel adapter. Use a hydrocolloid membrane on the patient's nose to help protect the skin. Secure the endotracheal tube separately from the gastric tube. If using a commercially available endotracheal tube holder, apply it according to the manufacturer's directions. If using adhesive tape, perform these steps. Cut and prepare a piece of 2.5 centimeter, 1 inch wide adhesive tape that is long enough to go along the bridge of the nose and around the tube several times. Secure the tube to the bridge of the patient's nose. Place a small fold on both ends of the tape and then cut or tear one end of the tape halfway up. Secure the uncut end of the tape to the patient's nose and securely wrap the 2 cut pieces of tape around the tube. Be careful not to pinch any part of the nares in the taping process. Reevaluate tube placement. Identify the tube's position at the nares using the centimeter depth markings on the tube. Hyperoxygenate the patient and suction the endotracheal tube and pharynx as needed. Confirm the correct tube position via a chest radiograph per the organization's practice. The tip of the endotracheal tube should be positioned 3 to 7 centimeters above the carina when the patient's neck is in a neutral position.